So our two so our two main objectives today are to one, just to quickly go over rate versus rhythm control in AFib, and second, to talk a bit about ablation in heart failure patients with AFib. So any discussion with about rate versus rhythm control, we need to talk about the traditional teaching that rhythm control is no better than rate control. And the question is, of course, is this still true? This is, of course, based on the old trial from 2002, the AFFIRM trial, which compared rate and rhythm control, and they found that rhythm control was no better than rate control and actually led to some worse outcomes, particularly hospitalization days. There's been a number of reanalysis and rethinking of this trial in more recent years. One of the big points that always gets brought up is that the rate of anticoagulation actually was quite subpar compared to today's standards. In the rhythm control group, you see there's this big difference between the rate of anticoagulation between those who were presumably were thought to be maintained in sinus rhythm with antiarrhythmics versus those who were in the rate control group. The other point that gets brought up a lot is that the pattern of antiarrhythmic use was a lot different back then. All patients had normal EF at entry into the group, yet you have a heavy use of amio and sotalol, and relatively lower use of propafenone and flecainide. Whereas modern day trends would be the normal EF and obstructive heart disease, our go-to would be flecainide propafenone before amio. Even they've done reanalysis and sub-studies. This 2019 reanalysis of FIRM showed that even though there was no benefit, again, always have to be careful when re-looking at studies with a negative outcome, but there was an indication that those who were put on rhythm control did have less heart failure. Again, all patients that were enrolled had to have a normal EF and could not have heart failure. And in this sub-study, developmental heart failure was defined as NYHA symptoms. So you see a difference here between the rate and the rhythm control groups. This is followed by the Athena trial in 2009. This is a trial of dronedarone versus placebo in AFib, not strictly a rate versus rhythm or even antiarrhythmic trial. It was simply dronedarone versus placebo in patients who had persistent or paroxysmal AFib, and there was found to be a difference between in terms of outcomes of cardiovascular death and hospitalization. This, of course, was attenuated. The enthusiasm for dronedarone was attenuated by the subsequent PALIS study. They basically saw these results and said, well, maybe dronedarone has a cardiovascular benefit on its own. So they tried it in patients with like permanent AFib, and obviously that caused harm. So the enthusiasm for dronedarone was reduced after that. Of course, we have to talk about the newest antiarrhythmic trial, which is EAST-AF, a trial from 2020, which enrolled patients with AFib onset less than a year. The average onset was something like a month, so actually very early in the AFib course. And they randomized them to rhythm control versus standard medical therapy. And they found there was a benefit in the primary outcome, which was a composite of cardiovascular death, stroke, hospitalization from heart failure, ACS hospitalization. Looking at the efficacy outcomes, you see when you split the treatment effect down, there was benefit in stroke here. Oops. And then a benefit in a CV death. There was also a trend of in a reduction of heart failure hospitalizations. The other interesting to point out is how many of these patients were actually asymptomatic, which was a fascinating aspect of the study. This is a sub-study of that EAST trial, again trying to split the outcomes by baseline EF. And you see they enrolled a fairly low number of patients with low EF. So your top right panel is reduced EF, your bottom left panel is mid EF, and your bottom right is preserved EF. And you see visually there's a greater separation of the curves. It didn't come out to be significant again because the numbers were so small, but certainly a signal that patients with lower EF may benefit more from rhythm control. So how about ablation in AFib and heart failure? So we know conclusively that ablation is much better than antiarrhythmics or rhythm control. I don't really need to show data for that, I think. The question now is, might ablation prove beneficial for patients with heart failure? The initial trial that started all off was the original Castle trial in 2018. They enrolled 400 patients with either paroxysmal persistent AFib, unwilling or intolerant to antiarrhythmics, baseline EF less than 35, plus NYHA 2 or greater. Everyone had to have an ICD implanted, so these were stable, treated patients on goal-directed medical therapy with ICDs in place. Of note, one of their exclusions was severe LA dilation. There was a big long list of exclusions, but they're fairly kind of specific scenarios and not much in the way of relevant exclusions. So these were the baseline characteristics. The age in the 60s, average EF was in the 30s, good spread of NYHAs, mostly in the 2 to 3 range. These were the outcomes for the original Castle trial. So the primary outcome was significant, which was death or hospitalization for heart failure. And there was actually also an improvement in death from any cause. And also when you split out the outcomes, a significant reduction in hospitalization for heart failure. This is just a slide from the supplementary showing how the efficacy of ablation. So as we know, ablation is not meant to be curative of AFib, but to reduce the amount of burden. And certainly that was achieved. The dark purple is the ablation, and the red is a pharmacologic arm. Contrasting that markedly positive study was this negative study from 2022. This is a Canadian study of about 400 patients with paroxysmal persistent AFib. Patients could have HFrEF or HFpEF. With this, BNP had to be elevated. The control arm was rate control without antiarrhythmics, and the intervention arm was ablation. Unfortunately, this study was quite tragically stopped at interim analysis because they determined there was only I think the numbers there was only a 19% chance of finding a significant effect. So this was stopped. But when they actually went and did all the follow-up, they actually found that the benefit of the ablation arm was greater than predicted by the interim panel. So there was a numerical and visual difference too between the ablation and medical arm, unfortunately not reaching statistical significance at 0.066. And we see here at the bottom a suggestion that maybe those with lower EF do have a bit of a better, more benefit from ablation. They also, this is the visual curves again for patients with EF less than 45 versus more than 45. And again, a greater separation of the curves with EF less than 45. But again, still not significant, but P equal 0.059. After the RAF trial came out, they did a meta-analysis looking at the benefit of AFib ablation in patients with heart failure, and it does come out to be positive at a hazard ratio of 0.06. So now moving on to the most recent Castle HTX trial. This trial looked at about 200 patients with so-called end-stage heart failure. This is a single German center that does something like 80 to 100 transplants a year, so quite a large heart failure center. The inclusion criteria being symptomatic AFib, all being evaluated for transplant or LVAD, and EF less than 35 plus NYHA 2 or greater, plus a decreased 6-minute walk. The arms were ablation versus medical management. Having said that, rhythm control was encouraged even in the medical management arm. So this is not necessarily a rate versus rhythm control trial, but really an ablation versus medications trial. They got an ablation median of 20 days after randomization. So these patients were flagged as high priority and shuttled right into the EP lab. This trial was actually stopped early for benefit. So looking at the baseline characteristics, again, age in the 60s. Average EF was below 30. It's about 29, 25, 29. NYHA, again, mostly in the 2 to 3 range, but kind of more deviate towards the 3 here. NYHA 1s were excluded, of course. And a good mix between ischemic and non-ischemics. In fact, more ischemics, more non-ischemics than ischemics. Average LA diameter 4.9 centimeters. Again, markedly positive trial. The primary outcome of death, urgent transplantation, or LVAD implantation was markedly improved in the ablation group. Looking at all-cause mortality, again, a marked improvement in the ablation group. Some additional endpoints, the EF increased by about 8% in the ablation group versus 1% in the medical group. This was at 12 months. AF burden was about 50% at baseline for both groups and decreased by 30 to about 20% in the ablation group, decreased by about 9% in the medical group. The ammo use at baseline was about 50%, and at 12 months, the amount of ammo use in the ablation group was lower compared to the medical group. So obviously, stunning results. Anytime Jarman Drola comments on Twitter or Medscape, it's always interesting to see what he has to say. He was skeptical, but sounds like not as skeptical as some of his colleagues. This borders on credulous, one of his friends wrote to him. So some of the criticisms, because anytime we have such a markedly positive trial, people, try to weigh in on the other end of the scale. So they thought 20% mortality at 18 months in the control arm was typically much better than what's typically seen in end-stage heart failure. The trialists, the authors conceded this point and said, yes, it's true. It's not quite as bad as other heart failure groups. Having said that, they also have a registry of patients waiting for transplant in Europe, and they said that this mortality was similar to what's seen. The second big criticism that came out, particularly on Twitter, was why was mortality seen so early here when the curves for the original Castle AF took a year or more to separate out? I looked at the mortality rate from the DAPA-HF, which is kind of the most contemporary heart failure trial I can think of, and I think the criticism of the mortality, there is a point. If you look at the DAPA at 18 months, the mortality is almost 15% already. And in Castle, the rates are kind of at 18 at 360 days, about 15%, a little bit higher at a year and a half. So one could argue that it is true that this population wasn't truly kind of what everyone in the world would consider as end stage advanced, with only heart transplant and all that left to do. Contrasting, this is a mortality curve from patients admitted for heart failure exacerbation, and we see that the mortality is much, much higher. At a year and a half, the mortality is nearing between 0.4, 0.5, so 40 to 50% at 1.5 years. So I think certainly that criticism does it does bear some validity. The second point of why the mortality benefit was seen so early, if you look at how quick patients got ablation, it was very, very quick. 40% patients, 40% of, again, the median time to ablation was about 20 days, and about 40% had it done, within days. So the trialist point was that in these patients, any recurrence back into AFib, rapid AFib, can markedly decompensate them and warrant a admission and possibly lead to cardiovascular death. Other points, there was concern that doing AFib ablations under GA would be detrimental. Like, could these patients with such low EF tolerate GA? The counterpoint was all these were done under local, under conscious sedation, which is what we do here in New Brunswick. And then the second point was that these aren't the traditional AFib ablation that take 3-4 hours. The skin time was 90 minutes, which is actually quite impressive. And then the other point was, for these patients, why not do amnio and cardio at first before committing them to ablation? And the counterpoint was that almost 50% of them were already on amnio at baseline. So a lot of these patients already had amnio and cardioversion trials and still were going back into FIB. So the main conclusions I have, I think, is one, rhythm control should be considered in all symptomatic patients with AFib, heart failure or not, and that stems from kind of mostly the EAST trial. Ablation is superior to antiarrhythmics for reducing AFib burden, and rhythm control appears beneficial in patients with heart failure and AFib. Okay, so that's what I want to talk about today. Happy to hear comments or discussion points.
Thank you so much, Dr. Weng. We have a few minutes for discussion and for questions. Anyone, please chime in.
Hi, it's Ron Bourgeois from Moncton. Great review and presentation, thanks. My question is, which type of patients with heart failure are we going to try to facilitate early access to ablation, and how would we be sending those referrals to facilitate that triage?
Yeah, right. So I've only been here a month and a bit, but I've already seen, obviously, as we all know, the wait time to get seen by one of us for AFib ablation is fairly long. But if patients are flagged to have low EF, we do our best to try to make them a 30-day like seen within 30 days or at least 90 days in clinic, and we do triage these to a higher level compared to, let's say, a younger patient with just paroxysmal and normal EF. So we are making an effort to get these people into the lab sooner.
Thank you.
Hi, Willy. Along the lines that Ron was asking, what are the sort of implications given the sort of resource tightness? If this provides the highest bang for your buck, maybe these should be prioritized largely. Is that a misread of me of that, given the burden of heart failure and all that?
Yeah, for sure. I mean, I think that's a concern with a lot of EPs around the world when they see results like this. The counterpoint would be this was a single center that obviously has a very streamlined way of getting patients in. They're a high volume heart failure center. They only had 2 operators do all these with significant experience, and they're in and out within an hour and a half. So I think, as always, there needs to be a balance between kind of access and also the clinical utility. I'm not sure I have a great answer up front, but certainly it seems like we should be doing our best to offer ablation to these patients.
So this doesn't really fit yet guideline based on the fact it's a single study and all of that. So it's not become the standard.
Right, but my feeling, my suspicion is going to be that now this is the initial Castle AF was so positive, a lot of people didn't believe it, and then after that, with this trial kind of almost reconfirming the results, I think there may be a lot of movement in the next set of guidelines. But we'll have to see kind of how this. It's still a fairly fresh study, so we'll have to see how it kind of shakes out in terms of guidelines.
Okay, thank you.
Hi, it's again. Sorry, just a quick follow-up question. So you pointed out the differences in the Castle AF and this pre-transplant group. They're both positive. Should we only be referring patients with advanced heart failure and AFib, or should we look at all our patients with low EF and AFib to be considered for ablation? And the sub-question is, which patients do you not want to have referred? The 80-year-old or other comorbidities that might make it less likely, mega atrium greater than 60, etc. If you can give some light on that.
Yeah, I think one of the keys is that 12-month life expectancy. So if they're being repeatedly admitted for heart failure hospitalizations, these were the patients in the Castle trial were still stable outpatients. I didn't see I looked for it. I couldn't see the stats on how many had a recent hospitalization heart failure. So I think there needs to be some common sense in terms of who to refer. And again, a super frail, extremely blown left atrium, permanent AFib. Having said that, the duration of AFib in these patients was several years, the 4 years average. So again, it's tough to say. I think low EF and AFib, if they seem like a reasonable ablation candidate, at least a discussion in terms of whether or not PVI ablation or even a CRT plus AV node ablation could be potentially beneficial.
Great, thanks for that.
And I should point out that LA diameter is 60 millimeters. If they're on transthoracic, their LA is more than 6 centimeters. We have a really hard time thinking of doing ablation for those kinds of patients.
Excellent. Thank you very much for the excellent review of this topic. I guess same along the lines of what you said. I guess the concerns, this is a single trial study, and it's always nice to have multi-standard studies confirm such impressive results. So, like you said, it's probably going to take a few years before it becomes guidelines, and because this is just hot off the press. And then, I guess the other question or comment that I have, again, it's going to be a question for us within the EP group. Like you mentioned, wait times are already, long. So patients with symptomatic AF, young, who are more likely to stay in sinus rhythm after ablation, where we have multiple studies showing benefits. And then if you add into the mix these patients with end-stage heart failure, if the results are indeed confirmed and we start doing those cases, how do you see that we balance resource utilization? Because if we start doing this patient end-stage heart failure right off the bat, within 30 days or how very early, then younger patients who have established multiple trials that show benefit are then pushed further out. And we know from the East AF trial that people who benefit from ablation, from rhythm control, is if you do it quite early compared to doing it much later in the course. So I know I don't have the answers, but I don't know. Have you had some thought about how we should prioritize those two groups?
Yeah, I think the easiest solution, the easiest thing for me to say would be we should just do more AFib ablations, right? But obviously that's a challenge in terms of getting resources. But even little things in terms of optimizing workflow, we'll see where pulse field ablation comes out across with all this. But if we can start doing more fibs in a day or having more fib days in a week, that's certainly one way. Because in the end, the reality is we have a fixed number of patients with AFib, a fixed number of patients with heart failure, and a fixed number of lab days. So we have to work around kind of either optimizing workflow, I think, or increasing the amount of ablation time that we get.
I think I have one hand up, Dr. Sharif.
Hi, Willie. Thank you very much.
Hey.
I just had a question about the 90 minutes of ablation time, because, I mean, that seems like that would obviously, were they using a different technique? Is there something that's different about it? Because obviously, if you could shorten your time to under 2 hours, then you're going to get a lot more ablations done in a day than if you're doing your usual kind of 4-hour procedure. So was there something that they did differently that you could tell from the study, or anything that you can adopt to actually speed it up?
I looked. Their flow, they're all RF, no cryos. Their ablation time, they actually don't use high power short duration. So they use longer lesions. They do fewer lesions than us. So I think there's a little bit of we're a little bit more careful about completing the lines, whereas in Europe I think they have bigger dots, visual dots, so they go around. It takes them fewer burns. Having said that, the 90-minute is actually not that unreasonable to achieve here. With high power short duration, we often are averaging about 2 hours anyway, skin to skin. So it's not that inconceivable. The other thing that a lot of these centers do is they do fluoroless, which it does save some minutes in terms of skin to skin, and has shown to be pretty safe and efficacious. But no, there was nothing like they weren't using a fancy new technique. They weren't using new technology. This was still RF point by point.
Okay, any other questions? Good. Okay, Dr. Weng, thank you so much for
Thank you, everyone.
Amazing presentation, and thank you everyone for great discussion. So this is definitely something to follow in terms of guidelines and further resource utilization and potential practice change. Thank you again, and see you hopefully next week. Thank you. Bye.